So before I jump into the actual evidence that I look at in this paper, I want to give you a little bit of context of why this was a concern of mine. And more or less, I suspect that many people here have experienced a subjective emotional state that they found distressful in one way or another. And I think that it's an open philosophic and scientific question whether or not that distressful subjective state is a biological malfunction, or on the contrary, there's something a bit more to it if the phenomenology of it indicates that there's other factors at work. If it's the case that depression is predominantly caused by a chemical imbalance, what that means is that when you experience the subjective state associated with depression, it's not necessarily something that indicates maybe something in my life isn't going like I want, or maybe I'm thinking about things in a way that's problematic. It's much more reductionistic. You're experiencing this depression because you have a biological malfunction in your mind. Now, like I said, that's an open question. My concern was that if someone experiencing those states labels their subjective experience in that way, that could be correct, but if it's incorrect, they might be disowning or alienating a part of their experience that could have treasures or potential boons for them if they were to investigate it further. So that's where I'm coming from. And if any of you have experienced a subjective state that you found distressful, I guess what I'd like you to entertain for at least a moment is that maybe there's a meaning-based element in that state, and instead of a chemical imbalance. Historically, the chemical imbalance hypothesis of depression is more or less, and this is a simplification, but more or less that you have a deficiency of certain neurotransmitters in your brain. The idea that depression is caused by a chemical imbalance initially originated, well, hints of it were available in the 1950s, and it came from two complementary directions, all based on kind of clinical observations and some small clinical studies that were documenting the effects of particular substances on the affective state of the patients. The first two antidepressants, and they weren't called antidepressants at the time, were iproniazid and imipramine. And I'm going to rush through this evidence pretty quickly because then we can get to a little bit of a more fun discussion at the end. Iproniazid was first used to treat tuberculosis, and it was not initially intended as a psychiatric drug. However, during its administration, clinicians noted that some of the patients given iproniazid experienced a boost in energy. And unlike typical stimulants, they didn't experience psychomotor agitation. And so they began to classify this as a psychic energizer. Trial runs were influential and sparked more interest, and about a year after the first publication came out, more than 400,000 depressed patients had been treated with it. Also in the late 1950s, a psychiatrist named Roland Kuhn published an article on the drug imipramine, and it also was not designed as an antidepressant, it was going to be used as an antipsychotic. Its chemical structure is actually very similar to thorazine. However, as Kuhn was using imipramine to help his patients with psychotic symptoms, he noticed that their affect, especially depressed mood, seemed to lift some. And he noted that many of his patients experiencing depression had a full social recovery. And by 1959, numerous different trials of imipramine had been conducted. And it was because of these two drugs that in 1965 and 1967, the first actual articulation of the chemical imbalance hypothesis was articulated by Schultz in 1965 and Cohen in 1967. Both of them argued that depression could be caused by too little of one or another neurotransmitters in the brain. In both of those articles, the justification, the scientific evidence used to argue the chemical imbalance always came from two directions. The first direction was that iproniazid and imipramine seemed to increase positive affect, so they lessened depressive symptoms. And they also knew that these two drugs increased the availability of particular neurotransmitters in the brain. The other direction that was very important was that a drug called reserpine decreased the availability of neurotransmitters, and it was widely reported that administration of reserpine was depressogenic. So when they combined these two sources of information, the hypothesis was very simple. If you give a patient a drug that increases the amount of neurotransmitters available, then they have a lessening of depressive symptoms. On the other hand, if you give them a drug that decreases the amount of neurotransmitters available, they seem to become more and more depressed. So depression is when you don't have enough neurotransmitters in your brain. So that was the story that came out of the 1950s and 60s. And so the problem with the story is that if you look closely at the evidence, it just does not match up. So let's first start with this idea of decreasing neurotransmission. Right now, researchers know that when you consume certain substances, that you can decrease the availability of neurotransmitters. And in 1979, Neoff and his colleague researchers did an analysis where they were looking at the administration of alpha-methylparatyrosine and parachlorphenylene, and these substances both decrease the availability of neurotransmitters. And so what it should do is induce depression, and it doesn't. And in 2007, roommates and Sheen conducted an analysis of all these depletion studies that have been done. There have been about 100 of them or so done. And they published a study in the Journal of Molecular Psychiatry. And the results of the analysis are there. They said there was never a reason to think that the reduction of neurotransmitters induced by these substances caused depression. So what we should be asking ourselves is how exactly does that make sense? Because we knew reserpine reduced neurotransmitters, and we also knew that it increased depressive symptoms. So why is it that that level of reduction in neurotransmitters causes depression that these other substances don't? And long story short, when more rigorous studies were done on the effects of reserpine, what they found was that reserpine was never depressogenic to begin with. It just doesn't cause depression. This is very odd because reserpine is kind of considered the classic example of a depressogenic drug, and it's still cited today in textbooks that reserpine induces depression. Baumeister, Hawkins, and Uzak in 2003 conducted a systematic review of the literature on the effects of reserpine. In that review, they examined the case reports and group studies that were used as evidence of reserpine's depressogenic effects, and they concluded, this is the only one quote I'm going to use for this talk, but it's quite good. Quote, the present review indicates that there has never been a good reason to believe that reserpine is depressogenic. Nevertheless, this belief continues to be widely promoted as established fact. The question that this raises is why the scientific and medical community would hold on to a belief so tenaciously in the face of evidence to the contrary. A plausible explanation is that this belief provides essential support for the monoamine hypothesis of depression, and that's the chemical imbalance hypothesis of depression. And I think it's quite telling to note that this study has had not one academic article challenge its findings. Another interesting feature of drugs that reduce the availability of neurotransmitters can be found in tianeptine, which is an antidepressant that's used in Europe. Most antidepressants used in the United States are SSRIs. Tianeptine is an SSRE, so it's a reuptake enhancer. It reduces the amounts of neurotransmitters available in the brain. It performs as well as SSRIs do. How is that possible? Why is it the case that both an inhibitor and an enhancer are both functioning just as well for depressed patients? So much for the idea that decreasing neurotransmitter levels leads to depression. Now, the overwhelming reason that people believe that depression is caused by chemical imbalance, though, has nothing to do with decreased levels of neurotransmitters. It has to do with the fact that antidepressants work. If you ask most people who take an antidepressant, they will tell you that they felt better. And psychiatrists prescribe them all the time, and there's a vast body of literature surrounding their efficacy. So maybe that's a leg that the hypothesis can stand on. The research on the supposed efficacy of antidepressants that I looked at was spearheaded by a man named Erwin Kirsch, and he started this research in 1998. I think it's important to note that Kirsch was not primarily a researcher in antidepressants. His area of specialization is in the placebo effect, where he's a world expert. But because of his interest in the placebo effect, antidepressant drugs were a very ripe target for him for two reasons. First of all, it's a very widely prescribed medication, and he knows that many medications have a pronounced placebo effect, so he wants to look at it. The second is that one of the primary elements in depression is hopelessness. And because one of the primary elements in the placebo effect is the installation of hope, of a different expectation, it seemed like antidepressants would be a very important area to study. So in 1998, he did an analysis of 38 different studies with one of his graduate students, and well, what they found was surprising to them because 75% of drug response was duplicated in the placebo group. And they couldn't understand how that could be possible. How is it that there's only a 25% difference in the response rate between the placebo group and the antidepressant group? This struck them as very odd, and so their first thought was, we must have done something wrong in our meta-analysis. And so they thought perhaps by pooling all of the different drugs being used, some of the lower performing drugs were bringing down some of the higher performing drugs. So they went back into the meta-analysis and looked at the different drugs and the way they all performed. And then they were very startled to surprise that all of the drugs were performing more or less the exact same. That means older tricyclics were performing as well as SSRIs, and these drugs were performing as well as drugs that weren't even antidepressants. The only commonality they were able to determine in all of these drugs was that they all had side effects. And so then they crunched the numbers on trying to correlate the amount of side effects experienced with the amount of improvement. For example, they found that the correlation between the use of Prozac and symptom lessening depression was 0.96, which is pretty high. He was eventually contacted by some researchers in Italy who did not buy this argument that side effects were such an important part of the effects of antidepressants, and so they conducted all of their, they conducted another study controlling for side effects, and they found no statistically significant difference. Another important thing to keep in mind is that there are trials that conduct clinical studies of depression where they use an active placebo, so placebo that induces side effects. And the vast majority of those studies don't find statistically significant difference between antidepressant drugs and placebos. Nevertheless, this was one study on one meta-analysis of 38 studies, and so the primary criticism that came after this meta-analysis of the study was that you have a bad data set, you don't have enough studies, and it just can't be the case that you could have been that wrong prescribing antidepressants all along. So in 2002, Kirsch and colleagues set about getting a larger data set, and this time they used the Freedom of Information Act to require the FDA to reveal all of the information on 6 of the different clinical studies, 6 different antidepressant drugs, all the clinical studies. Now the reason that's important is because pharmaceutical companies own the data that they gather when they conduct clinical trials. They do not have to publish a trial if it doesn't show the results they want. However, the FDA requires that any drug being submitted for approval has to submit all of the different trials that they've used. So they got access to a bunch of studies that weren't initially publicly available. They crunched the numbers on this, and what they found was that 80% of the drug response rate was duplicated in the placebo group. And this time around, there wasn't going to be any complaints about the inadequacy of the data set because this was the data set that the FDA used to approve the drugs and include every clinical trial that had been conducted on the drugs. So it's important to note that they did find a statistically significant difference between drug and placebo. It was very small. However, Kirsch wanted to make clear that there was not a clinically significant difference. So to give you a better idea of what that means, the difference between drug effect and placebo effect in these groups was about 2 points on the Hamilton Depression Rating Scale. And generally 3 points is what's thought to be indicative of a clinically significant treatment. And so these drugs are in a clinically significant way performing better than placebos. So, and this data has been replicated numerous times by other independent researchers, and it's also been replicated by researchers that the FDA had to look at their own studies. So when you look at these 2 lines of evidence, the hypothesis emerged from the idea that it's because there's some type of fluctuation level of neurotransmitters that people experience depression. But both sides of the arguments, both decreasing neurotransmitters and increasing neurotransmitters, they don't really paint a very good scientific picture of the evidence there. But even still, most people there just must be something wrong because the chemical imbalance theory sticks around and the antidepressant drugs continue to be prescribed and the FDA continues to approve them. So in closing, I want to mention at least 3 reasons I think the chemical imbalance theory sticks around. The first is that from the very beginning, the chemical imbalance hypothesis was funded by pharmaceutical companies. Most of the pharmacologists looking into these compounds were working for pharmaceutical companies or intimately related to them. These companies make more than $10 billion a year in the United States on antidepressant sales, and so they're not just going to pack up their tent just because the data doesn't fit nicely. If it's the case, they can still make a profit selling their drug. The second reason is that customers keep using antidepressants, and when they use them, they do feel better. And that's an important point. The only issue here is that it's not that when patients use an antidepressant, they don't feel better. It's that they would feel just about as better if they were using a placebo, but they don't have a control group of themselves to compare to. They just know that when they take the antidepressant drug, they feel better. The final reason I'd like to suggest that it sticks around is related to something Stacy mentioned, which is there's a preoccupation in psychiatry with explaining subjective experience in relationship to the brain. Also, Stacy mentioned this is a philosophic problem that's come back for quite some time. In the 20th century, it really saw a manifestation in a 1956 paper called his consciousness of brain process. And this idea that the mind just is the brain has been accepted by prominent psychiatrists and incorporated into reductionistic accounts of mind. However, I think the problem here is that really ignores a lot of the work in philosophy of mind that's been done, which calls into question reductionistic accounts of mind, as well as the idea of reduction as a whole. For example, the idea that the mind just is the brain has been thoroughly critiqued by philosophers for quite some time, and one prominent line of reasoning they suggest is that a functionalist account of mind, not a reductionistic one, better explains the workings of mind. And I think the easiest metaphor to use to explain this is you cannot understand the computer programming of your operating system on your computer by taking a very detailed look at your hard drive. You can understand it if you look at the symbolic representation of the programming. And the same line of thought holds for psychiatric disorders. You aren't going to understand it by trying to take a very detailed look at the way particular groups of neurons are communicating with one another. But if you appeal to the symbolic level, the meaning-based level, you can find something useful there. Well, I'll just leave it at that.